Thank you very much. Thank you very much, dearest brother. Thank you for your kind words. I'm always happy to be to join and participate in these webinars. They are really informative, and I do believe that I'm still a learner. And I always love and like to learn from you, dearest brother. Thank you very much, and I hope all members of APEC will benefit from these scientific meetings. Thank you always. You are great as always. Today you are more handsome. I don't know why, Mohammed. Something happened. Perhaps
no, nothing happened. I just traveled to Beirut first for APEC with you and meet you face to face. That was a great pleasure to meet each other after 2 years locked on in our houses behind our computers. However, still, I love this type of communication that we can see each other, communicate with each other. Fantastic time. And after that, I have a very good experience of traveling to Syria, meet a lot of Syrian friends in a huge number of participants in a very great Congress. That makes me very smart. Why not?
You look great, you and all the colleagues participating in this great discussion. And I want to thank you and take the opportunity to thank them all for their participation. And I hope we will enjoy them in the discussion today as in every meeting. Thank you very much.
Yes, Mukhtar should be ready because we put him in a very hot chair. We are going to ask him a lot of questions.
I'm ready, but I hope at the same time that you will be a little kind to me.
Professor Abutown always advised me not to be harsh to the authors, but I will be. By the way, I'm going to introduce also Dr. Mahsa Nehmatnejad from Azad University, Islamic Azad University from Tehran, who is also supervised by Professor Mahta Fazliab. Mahta, can you start actually your video and tell us some introduction and speak about Mahsa as well?
Hello, everybody. Good afternoon. Hope you have a good time. Thank you, Professor Nekufar, for having us with you. As you said, Mahsa is the second year Endodontics in Islamic Azad University, and special thanks to Professor Nekufar who let us just present the article in the presence of the authors. This is an honor to us.
Thank you very much, Mahta. And we have our young fellow, our future endodontist, and these young fellows are going actually to be the future leaders of endodontic in APEC, in IFI, in the local association, obviously. So, Mahsa, please introduce yourself. You have 1 minute to introduce yourself before we officially start. Please.
Yes, hello to everybody. I'm Mahsa Nehmatnejad, postgraduated student of endodontics. And thank you, Dr. Nekufar, for giving me the honor of this presentation. And I'm very glad to in your accumulation, and I'm very happy.
Thank you very much. We also have Professor Kazandak, Meriç Kazandak from Yeditepe University. She's also very active, always very supportive. Meriç, do you want to say something? Okay, Professor Kazandak, maybe when you connect. Oh, ahlan wa sahlan, assalamu alaikum. I can see now Shazra Fatima. Assalamu alaikum, Shazra.
Wa alaikum assalam, sir.
Shazra is the first author. We are very happy to have you.
Thank you so much, sir. Thank you for the opportunity, sir.
But we are going to be very harsh. Be ready for the questions.
Okay, sir.
Good. You have a very good teacher. We have a very good teacher. I know Mukhtar very well. And I'm going actually to surprise you because I'm going to ask Mukhtar to start the session officially by reading a Persian poem. Although he's an Indian, but he knows a Persian poem very well. He actually recited that for me when I was in India. And I separate that film to all of my friends. You can find it in my Facebook event. Mukhtar, please go ahead, and I will translate that to English.
That's what is so good about you, that you still remember that verse, that couplet, which I had read in front of you around 2.5 years ago almost. and it's a Persian couplet, because you see, I'm from a place in India which was earlier known as Iran Sagir, the little Iran, Kashmir.
Wow.
So Kashmiri language basically has the Persian script, Arabic Persian script. The letters are same. So there is a little bit of Persian mixed with Kashmiri as well. Although the origin of the Kashmiri language is from Sanskrit and this Persian mixture. So the couplet is, it's a very good couplet. Man tu shudam, tu man shudi, man tan shudam, tu jan shudi, takis nagoyed badazi, man digaram, tu digari.
Well done, very well. Can you translate it yourself, or do you want me to do it?
I can the translation is something like this: that man tu shudam tu man, you become me and I become you. You become the body and I become the soul. So let's not say from hereafter that we are separate.
Oh, great.
Very nice. Very nice.
Is this Sufi poem?
It's a Sufi poem.
Yes, it is. It is. Actually, it is. Yes, yes. Thank you very much. That is a first surprise. I have a lot of more surprise today. Before that, I'm going to ask Marriage to say hello. Marriage, please.
Hello, everybody. This is Marriage from University Istanbul, Turkey. Thank you very much for organizing this event, Dr. Nekofar.
Thank you for supporting us. And we have Professor Monsef as well. Welcome to Professor Monsef from Mashhad University. A lot of professors and students and colleagues, endodontists from around the world. And I'm very happy to see all of you. So my second announcement is about the program. As you know, so far we had 8 APEC online journal club, and we are very proud of that. The outcome and the feedback was fantastic. And these days, one of the very important new index for academic collaboration names Open Science. Open Science is a new way of ranking universities and academics and professors around the world. That means whoever share their knowledge with others freely, openly, they get more credits. They don't look at us anymore based on our H index, which is related to the numbers of citations that we have received. They look at us about how generous we are and how we share our knowledge with others openly and freely. And this is the motto of the Educational Committee of APEC, based on the leadership that we have received from Professor Abu Tahun and continued by Professor Sanjay Miglani now, that they told us we need actually to do that without any, and that the session is all open and free. And you can see that we did everything based on the support that we have received from the university, Tri-University of Medical Sciences so far. And we are very happy to have actually a sponsorship from Woodpecker from now as well. So what we decide to do, because when we start these sessions, we start that on Fridays evening based on the local time. Now we called it Eastern Zone. We are planning to start actually a Western Zone program as well, which is every 3 weeks. So rather than monthly program, we are going to have every 3 weeks program, one for Eastern Zone time, which is on Fridays, and the second one is on Saturday evening, which we will actually announce that very soon to everybody. And therefore, if I want actually to tell you about the next session is about another article by a professor that comes from America, and the program will be on Saturday. So please be ready for our next session, which is on Saturday in 3 weeks rather than in a month. Therefore, every 3 months, we are going to see each other. If it is on Friday this time. The next one will be on Saturday. And after 3 weeks, it will be on Fridays. So every 6 weeks, we have a Western program, Western Zone Time program, and every 6 weeks, we have Eastern Time program as well. It is because of the demand from different countries. As you know, in Seoul, it is 10 o'clock. So our president, Professor Kim, is 10 o'clock or almost at the end of the day. And for us, it is afternoon. For somebody, it is in the morning. That's fine. Thank you very much for joining us, Professor Al-Huwaizi from Iraq. Please tell something, and we are going to start almost.
Oh, it's very nice to be with you. Thank you very much for this occasion, and I'm very happy to be with you.
Thank you very much for your support. And we have Professor Hessam from Denmark as well. Hessam, please. We are happy to have your introduction. Professor Hessam, please unmute yourself. Please unmute yourself. Hessam, we cannot hear you. Hessam, please unmute yourself. Not yet, not yet. Okay, maybe when you unmute yourself, we are happy to receive your introduction as well. So I'm going to ask Mahsa now to start the presentation. Mahsa, please feel free to share your presentation. And Mahsa is going to give us an idea, a whole idea about, as usual, about the article. And then after that, I may start Mahsa and I may ask Mahsa to unshirt, and then we will discuss and we ask our question from the first author and from the corresponding author. Mahsa, the stage is yours. Please go ahead.
Yes, hello again, hello to ladies and gentlemen, and thanks thanks to Professor Fatima, Professor Kumar, Professor Andrabi, Professor Kumar Mishra, and Professor Kumar Tewari, and thanks to Professor Fatima and Professor Andrabi for being with us. The topic of this article is effect of apical third enlargement to different preparation sizes and tapers on post-operative pain and outcome of primary endodontic treatment, a prospective randomized clinical trial. Endodontic therapy aims to eliminate microbacterial infection from the root canal system and prevent its reinfection. Apical third of root, this area serves as a niche for the residual microorganism because of the presence of this distinctive anatomic variation considered to be a critical zone. As we know, larger apical preparation size has some advantages and disadvantages, like disinfection of the canal, unnecessary removal of the dentin, weakening of the tooth structure, penetration of irrigants, reduction in the number of residual bacteria in the root canal system, and post-operative healing of apical periodontitis and post-operative pain after endodontic treatment. The present study was designed as a randomized clinical trial to evaluate the effect of apical preparation size and the sizes and taper on the post-operative pain and healing after primary endodontic treatment. Inclusion criteria was healthy ISR1, either sex, 14 to 65 years of age, asymptomatic apical periodontitis in the mandibular first molar with radiographic evidence of periapical radiolucency corresponding to a periapical index score 3, as you see in a slide. And exclusion criteria was medically compromised, pregnant, uncontrolled diabetes, smokers, and history of analgesic intake in the past 1 week. For randomization allocation concealment, an equal proportion randomization allocation ratio was used to randomly assign participants into 2 groups and 2 subgroups. A random number sequence was generated by the central administrative authority not involved in the study for particular groups and subgroups, which were assigned sequentially to the patients fulfilling the eligibility criteria. Patients and the primary investigator were belonging to the allocated group. As you see in the fellow chart, 120 patients enrolled to this study, and no one was excluded. According to randomization allocation, there was 2 groups, and each group had 2 subgroups. In group 1, apical preparation size was 2 sizes larger than initial apical bonding file, and in group 2, apical preparation size was 3 sizes larger than initial apical bonding file, and each group had 2 subgroups according to taper. Subgroup A had 4% taper, and subgroup B had 6% taper. As you see in table 1, the mean age it was 30.85, and male and female that participated in this study was almost equal. In first appointment, access cavity prepared and establishment of the patency using a number 10K stainless steel file and coronal and middle third fillering using high flake CM rotary file with an 8% taper. Irrigation with 3% sodium hypochlorite using an 27 gauge side wanted irrigation needle, and determination of working length using an electronic APEC locator and a diagnostic file radiograph. The length was measured, and 0.5 millimeters was reduced from the measured length, and this length was confirmed using a straight and angled radiographs and was opted as the final working length. Take a moment, please.
So I think that's a good time actually to ask I don't know, any of you, maybe Shazra or Professor Andrabi, any of you, you can answer my question. Please unshare, can you unshare, please? Mahsa?
Yes.
Please. Because I want to see them all. Yes, that's a good one. Okay. Shazra, we understand that actually in this study, you try to compare the apical enlargement, in which you tried actually somehow standardize the coronal preparations same as each other and just different apical enlargement. Am I right about that? It is the first question.
Yes, sir. That is why we did the coronal and middle third flaring with the 8% taper, so that the coronal and middle third flaring should be same in all the groups. We will be differing in the apical third preparation in all the groups.
All right. So as Masa showed in her slide, you actually just use same diameter in the coronal part and different diameter in the apical part, and you confirm that. But the question now comes, because we don't have any standardization in terms of the size of the canal, in terms of the cases, obviously, we cannot claim that all the molars are similar to each other. So maybe one of them is larger than the others. So making the standard is a bit difficult. And I understand you use the initial file, and then you claim that you enlarge the canal 3 files larger than the initial file. Is it correct?
Yes, sir.
And do you want to confirm that as a guideline for our clinical preparation when we clean and shape the canal? Should it be like that always or not?
No, sir. Sir, I clearly didn't understand your question, sir. Can you repeat, please?
The question is, which file is the last file for our enlargement? Is it always 3 times larger than the initial, or can we go 4 or 2 larger than initial file? Because that was a discussion. We don't know actually what is the best file as the master apical file. Because in your study, you give us some standard. You say that, okay, the initial file that binds in the apical part, we need to go just 3 larger than that to make it a standard. I agree with that because you want to make it a standard. I agree with that. So is it something that we can recommend to everybody to follow that or not? And is it enough cleaning and shaping or not?
I would like to say.
Okay, Mukhtar, please go ahead.
What we were trying actually to find in our study was that what should be actually the minimum practical preparation, wherein neither the biological principles are compromised nor the structural integrity of the tooth is compromised. You see, what we have right now in our literature, we see a plethora of systems are there for preparation of root canals. And all of us know the main aim of each and every root canal treatment procedure is that we need either to treat the apical periodontitis or to prevent it from developing. That is a disease with an etiology and a biological basis. So our aim is to get rid of the etiology which is leading to the disease. So what should be the minimum standard which will result in an acceptable and a practical level of debridement within the apical thirds, because apical third is a zone which is very critical, where the anatomy is very critical. You have variations in the apical third. You don't have a straight canal everywhere. A straight or a circular canal is a rarity. Canals take all the bizarre shapes that will come to our minds. So with the systems available, you can some say that even just this small, keeping the apical third as small as possible, it's okay. And some may say that enlarging to a larger size. And
Mukhtar, can you come a bit closer to your mobile or to your desk laptop and speak louder, please?
Okay.
And Mrs. Sadeghi, can you start also send the subtitle, because we can have subtitle automatically as well. Okay, please go ahead, Mukhtar.
Okay. So therefore, our study cannot give that this is a standard guideline, but our study definitely can give a guideline that this is a particular size. If you keep less than that, the debridement may not be adequate. That was our main conclusion of the study. So what we did, as you said that you used almost 8% for that 8% is a standardized, what we call as an orifice shaper. Any orifice shaper we take, that is an 8% taper or a 10% taper. So that is just to have the idea of initial apical diameter as close as possible, because we in endodontics, a lot of discussion is always there in every forum on working length, but there is a forgotten dimension, which is working width, the width of the apical third, which we call as the working width. So in order to have the estimation of that initial diameter as close as possible, we need to have sufficient enlargement in coronal third and middle third, so that the files go into the apical third without binding anywhere else except in the apical third. And after that, we need to know how much we can enlarge in each and every apical third. That's
okay. That's very good. Thank you very much. And what about the obturation? Because we are worried if we don't have enough coronal enlargement, especially in the group that you use the least one. do you have enough place for compaction or lateral compaction or not?
Of course, I think with 8% taper, you get sufficient space for compaction, and for you can get adequate obturation. And,
okay.
And as
so there are two things. First, get rid of the bacteria, and the second is prepare that for a good obturation and good sealing ability. Thank you. And there is another question from Hassam. Hassam asked about the is it ethically acceptable to make two radiographs for working length measurement while we have electronic APEC locators? And what was the reason behind taking two radiographs for that purpose, and why you don't use apical APEC locator for that purpose?
We use APEC locators, but since Shazra was undergoing that our postgraduate training at that time, it's in our postgraduate training curriculum. We still it's in our guidelines that while you measure the working length with the APEC locator, then you take a confirmatory radiograph as well, because in terms of record keeping, still when you are going to publish or something, working length radiographs are what we call as needed.
So usually, do you recommend taking two radiographs just for working length measurement?
No, we can go for one as well, but we can take a confirmatory radiograph.
Okay. Okay. Is there any question from the audience? Is there any question about this part so far or not? If there is any, you may type it, or we can also, you can start turning on your microphone and speak. Okay, nothing so far. We are going to have a very short break and carry on. Mrs. Sadeghi, please. Masa, carry on, please. Share your PowerPoint and carrying on speaking about the methods.
Back to topic. The first standardized hand K file that snugly fit at the working length was considered as the initial apical binding file. Biomechanical preparation was performed using high-flex CM rotary file with the master apical file size set at 2 sizes and 3 sizes larger than the initial apical binding file, respectively as follows. Group 1, subgroup A, 2 sizes larger and with the 4% taper. Group 1, subgroup B, 2 sizes larger and with the 6% taper. Group 2, subgroup A, 3 sizes larger and with the 4% taper, and group 2 subgroup B, 3 sizes larger than the initial apical binding file with the 6% taper. Irrigation with 5 milliliters, 17% EDTA, and final rinse with 5 milliliters, 3% sodium hypochlorite. Drying canal with stereo absorbent paper point and calcium hydroxide mixed with the normal saline in the paste-like consistency used as a dressing. Cavity used as temporary restoration. Participants when they briefed about the VAS and
Masa, I want to stop you again because there are some questions from the authors. Sorry about that. Please unshare. The first question is from Trat Khaireddin, that he said we have to respect the radicular structure as minimal as possible to avoid the weakness of this structure. TUMS treated endodontically will have a lot of modification. This is why it have to be as minimal as possible. I think it is like a comment. If Mukhtar or Shazra wants to add anything, please go ahead. It looks like a comment and an advice. We all agree with that. Is there any comment about anybody?
Of course, I absolutely agree with that. We have to respect the radicular tooth structural integrity. It's very critical. But at the same time, the purpose is debridement and disinfection of that area as well. We have to get rid of all the bacteria, endotoxins, and everything. So we have to create a balance, a harmony between how much we have to prepare so that we don't weaken the tooth and at the same time, we don't have inadequate disinfection.
Yeah, that's very important. This balance, I think, is one of the very important and take-home message for all of us, that we need to respect the radicular part as well as we need to make sure that we get out the bacteria from the apical part at the same time. Another question, which is a bit tricky question, from Professor Zargar. She said that, with greetings, would you please explain the type of the randomization? Shazra, do you want to speak about that?
Yes, sir. Sir, actually, it was a block randomization. When the patient came to the clinic, he was assessed for the eligibility. And if they were included in the study, then they were central administrative authority was contacted, where a randomization code was assigned to the patient, which was directly communicated with the clinical assistant. And the randomization code, as well as the allocated group, it will be communicated with the clinical assistant. The clinical assistant will reveal this code and the treatment group to the operator once the informed consent has been obtained from the patient. So it is a type of a block randomization where the blocks are a size of 4 and 8.
Because the next part of her question is about, is it stratified? But when you explain like that, it wasn't stratified. It was completely random.
No, it's not stratified.
So actually, we cannot stratify because it is very difficult to enroll so many patients at one time, and then we have to stratify them in certain groups, and then we have to randomize. That's a very difficult thing to do. So what we did is block randomization is, as the patient comes, we randomize them and we do the intervention like that. We're going.
So in that case, you were not worried about the standardization of the coronal part and apical part in both groups? Because with stratified, you may actually allocate it yourself and send it to each group that you want and make it more standard. Make two groups are very close to each other. However, you showed that at the end of your study, when you did your regression, you showed that your two groups were how similar they were. I know that. But do you think which type of randomization is more accurate? I think if Professor Zargar if she wants to speak herself, we are happy actually to have her. You carry on. If she turn on her microphone, she can directly speak with you. Please, you carry on answering the question.
Yes, sir. Sir, the accurate obviously is the stratified one, but there's the problem with the stratified one is that we have to enroll all the patients all together, and then we have to distribute them accordingly. Then we have to do the randomization. In our setup, it is a little bit difficult to do. Although block randomization, it does not take into account the confounding factors, but it is a good randomization scheme if we want to keep the number of subjects equal in all the groups. And then obviously later on we also assessed the correlation and regression, and we found out that there was no significant correlation between the age, gender, and other factors on the outcome of the treatment. So
I'm convinced, but I'm not sure about Professor Zarga. If Professor Zarga is not convinced, I'm happy to have her. The next question is from Professor Nazari Mugaddam Kumars. He said, although the coronal enlargement makes it easy to get rich to the apical third, the root curvature impedes further penetration. How to manage this problem? So this is speaking about the apical part. If you have a curve, because you haven't mentioned anything about the curve measurement or the measurement of the apical part in terms of curvature of the root. Can you explain it a bit more, maybe, Professor Mukhtar?
Actually, the study did not include those cases wherein the curvature was greater than 20 degrees. It was just between 20-degree curvature. So then in those cases, we did not have much problem while negotiating the apical third. And mainly, even if the canals are curved, the negotiating files or the pilot files like number 8, number 10, you can negotiate with them. And then after that, you can shift to an IP file. That's it. But
the next question is about the total volume of irrigant, because you just mentioned about the volume of your irrigant as when you wanted to remove the smear layer, but not the whole volume of irrigant that you used during the study. Shazra.
Sir, after each instrumentation change, whenever the files we were changing, sir, we used to irrigate the canal at least 5 ml with sodium hypochlorite. Sir,
right.
as we can
5
see,
5 ml between each file. You didn't mention that in the article.
Sir, actually, as we can see that the number of files will vary according to the groups. The smaller preparation sizes will have a lesser amount of irrigant, because in file size 30, we will go 3, number of files will, the change in the number of files is higher as we go up the group. So the the volume of irrigant will also increase accordingly.
Yeah, so that can be a source of some sort of discrepancies between the group. That we discussed that with some of our colleagues about that, because the volume of the irrigant may have some effect on the post-operative pain. So if in 2 groups, the volume of the irrigants is not equal, that can be a source of the discrepancy between groups. However, Professor Abu Taun told me not to be harsh, but that is a very harsh question now.
Of course, that's a very good question, that if the volume of the irrigant varies between 2 groups, and there may be a difference in the post-operative pain. But that will be only in cases if the irrigant extrudes. And if our preparations are what we call as with patent apical foramen, we are enlarging the apical foramen as well. But if we are keeping, we have our working lengths where we work short of the apical foramen. We worked around 0.5 to 1 mm short of the reading of the apex of the penis. So
yes.
There was not, and moreover, the concentration of the irrigant which we are using, sodium hypochlorite, we are using 3%. So it's towards the lower side. So because we know that anything greater than 1% has a good antimicrobial efficacy. The only difference is their in tissue dissolving abilities. So that may be the reason. But
okay, and there is also another question about the number of the times that you used the files. How many times files were used? More than once?
I don't understand this. Means
you throw out away for each case, you use just a single file, or you use the file for a case twice, for a second person?
the files we usually use the high flex files as per the manufacturing instructions. We don't use if the cases are moderate, we use them for a maximum of 3 or 4 patients, not more than that.
Okay.
No, we did not use single use files.
Okay, and another question is about, in all participants, high flex file reached the apical part. Is it correct? So when you introduce the first high flex part, you managed to go to the apical part in the first attempt or not?
No, not in the first attempt. It's in the sequential order. What we have mentioned is this is the final size. That is the final size. That is the final size.
Okay, the final size.
Final size, okay? The final preparation size. Otherwise, the
sequence. Okay, so before we go back to the next part of the presentation, the last question is about the use of calcium hydroxide. We discussed about calcium hydroxide for a very long time in our previous sessions. Some of us are against, some of us are in pro, so I am not going back to that discussion. However, in such a study like that, if we use calcium hydroxide, it may have a direct effect, a good effect, or maybe a bad effect. I'm not discussing that on the post-operative pain, which was your first outcome. In that case, if your outcome was about the pain, why you use calcium hydroxide between appointments? Maybe it was better not to use anything, just to concentrate on your apical enlargement, not just other things. What do you think? Why you use calcium hydroxide? Tell us about that.
That's a good point, but we wanted to conduct the study in the way that we are doing our routine endodontic treatments. We routinely use calcium hydroxide as an intracanal medicament. We usually, most of the time, we complete the molar treatments in 2 visits. In the first visit, we complete everything, debridement, disinfection, preparation, and you place a medicament that is calcium hydroxide. In the next visit, we obturate. So that's our standard practice. So we just wanted to, and that is a standard practice, I think, in most parts of the world. In this part of the world, it's a standard practice. In India, most of the cases are done like that. The calcium hydroxide is used as an intracanal medicament. And there is ample literature available which supports the use of calcium hydroxide medicament as for disinfection, for enhancing the disinfection, or for creating the environment within the root canal system non-conducive for further bacterial growth. Because post-operative pain was not our only aspect. Our aspect was also the healing outcome.
Okay,
so that's why we.
There are much more questions. Before we go for that, I'm going to ask actually Mahsa to go further, speaking about the other parts of the methodology, and we come back for the question. Mahsa, please go ahead.
Okay.
Yes, participants were then briefed about the VAS and subsequently trained by a single instructor to mark the intensity of pain experienced by them at 6, 12, 24, 48, and 72 hours. Telephonic assistance was provided to the patients to record post-operative pain on the VAS at different intervals. Patients were instructed to report after 1 week. In second visit, patients were asked about any signs and symptoms and clinically verified by checking tenderness and percussion of the tooth. In the absence of any symptoms, canals were irrigated with 3% sodium hypochlorite to flush out the intracanal medicament. Irrigation with 3% sodium hypochlorite with manual dynamic agitation using a gutta-percha cone. Final rinse with 5 milliliters normal saline, and obturation using gutta-percha and zinc oxyuronal-based sealer using the cold lateral compaction method. Post-endodontic restoration using amalgam and taking a baseline radiograph using preset exposure parameters and paralleling technique. Primary outcome measurement was pain assessment at 6, 12, 24, 48, and 72 hours by VAS technique, and change in periapical radiolucency at 3, 6, and 12 months by Periapical Index score. And the secondary outcome measurement was about clinical success. Clinical success was absence of pain, absence of tenderness on percussion or palpation, no association sinus tract or evidence of soft tissue swelling, lack of abnormal mobility of the tooth, and periodontal probing depth within normal limits. Periapical Index score evaluation performed by 2 independent examiners belonging to the study aim in a dimly lit room, and only the periapical area and the apical 2 to 3 millimeters of the root canal were visible. Examiners were pre-calibrated by methods of Wang et al. And performing the scoring again at the interval of 30 days. In dissimilar scores in individual roots, the overall scores was the highest periapical index score. And in disagreement between the scores, when there was disagreement between the scores, the investigators were asked to meet and discuss. About the statistical analysis, Shapiro will test.
Okay, can I stop you, please? Can I stop you before you go to a statistical analysis? Please unshare.
Yes.
Okay, thank you very much. The first question that now we have, I want to ask the person who wrote these questions to speak themselves. Professor Nazari Muqaddam, Professor Fazliab, Professor Nayer Abu Al-Sad, and others. If you are ready, please go ahead and ask your question. Mahta, please. Please unmute yourself. Yes.
Done. That's done. I have a question here. When we discussed this article in our national meeting, a question came to my mind. I wanted to ask the authors why you didn't just set a minimum standard for the initial file. For example, if one tooth had the initial file set at 10, in group 1A, you would have two sizes of preparation and enlargement and a 4% taper, which makes it almost 25. Is a 25 or 4 enough preparation size for reducing the bacterial contamination in apical area? And do you find it enough? Do you think you could have just set a minimum in your inclusion criteria at least, or even you could just mention that during the procedure, if such thing happened, you would exclude the patient. What is your idea about that?
So you asked a very
Okay,
good
please. Yes.
Am I audible?
Professor Andrew. Yep.
Am I audible? Okay.
Yes, please.
You said, you asked a very good question. Actually, the whole study is about that. If you will go towards the conclusion of the study, you will find that
Mukhtar, please speak louder. Please speak louder or closer, please.
I think there is.
Oh, that's much better. Much better. Yes, okay. Thank you.
So basically, if you go towards the end of the study, while you will read the conclusion and the discussion, you will find that 25.4% is an inadequate preparation and didn't result in what you call as an acceptable success rate in our cases. And in those cases wherein the periapical lesions did not heal at 9 months, then those cases are where the symptoms persisted. Those cases were again retreated, but counted as a failure in this study. So we were actually trying to set that standard that what should be the minimal preparation, that if actually each and every preparation, we cannot standardize all the canals on that. What we can standardize is that what the initial diameter is, and then how much we have to go beyond that in order to achieve an acceptable debridement. It all will depend.
Mahtad, are you convinced? You can carry on talking, please.
I think that Professor Mokhtar, they are just mention what they found as a result. I think if you could just set a standard for this, this is a finding of the study. You said that you at the end you just said you found out that the minimum apical size should be at least, for example, this number. Okay. I said something else. I just said that you could have mentioned it as a limitation of the study, or even just set a minimum standard for the apical size. You did not exclude the patients if should any patient was with the apical initial file size, that did you exclude or not? You could at least mention that.
No, I accept that as a limitation of the study. I accept that as a limitation of the study, and maybe
that was what we discussed actually. Okay. Exactly. Okay, that's good. So, Professor Nazari Muqaddam, there is another question from Professor Nazari Muqaddam. QMers, are you ready? Please turn on your microphone and ask your question. I can read your question, but I prefer actually, if you have that question, you can go ahead. Professor Zaga asked me to read her question. Professor Mukhtar and Dr. Shazra, the question is, how did you calculate the sample size? According to the aim of the study, is it enough? The effect of many variables was evaluated. Was the design suitable for healing outcome studies? Because when you are looking for post-operative pain, maybe the number and the sample size looks enough. But when it goes to the outcome and you are evaluating the effect of different variables on the outcome, then you may need more sample size. What do you think about that? And can you explain for us?
So actually, the sample size was calculated based on the standard deviations from a previous study that was conducted in 2012 by Dr. Saini et al. And based on
post-operative pain, or for outcome? That is very important. For outcome, okay.
The sample size was based on that. And so if we calculate the sample size for post-operative pain, it would come much lesser than this sample size. The sample size was larger for the PAI scoring. That is why we took the larger one. And it was based on the standard deviations from the study of Saini et al. In the year 2012. And I think the sample size was enough to address the aim of the study.
Okay, no, that is good, because the question is about that. If you calculate your sample size based on the long-term outcome rather than the post-operative pain, that is good, because your regression also showed that the sample size, at least for some variables, were enough. But for some variables, if you want actually to calculate the difference, you may need more sample size, that you already mentioned that in your manuscript as well, your publication as well. Thank you very much. That is very clear now. Thank you very much. And QMARS, please go ahead.
Hello, everyone, and thanks, Dr. Nekufar, for this conference. I have two questions. First, we have no difference in regarding pain and swelling between one visit root canal treatment and two visits. Another question is, according to the published articles, we need at least size 40, 0.04 for enough irrigation circulation at the apical third. And when we choose the number 14 or 10 at the first bonding file, and then prepare two or three number, I think it isn't enough, because we know that we have many difficulty in circulation at the apical part. And also I have another questions that maybe
QMARS, please let Mukhtar and Shazra answer your first questions first,
yes.
And then we go back to you. Any of you, Mukhtar or Shazra, please.
Thank you, doctor, for the question. I understand your question. Actually, he's saying is that the sample size, the minimum preparation size of the apical third must be at least 40. Actually, you see what there is still a debate on this, regarding the preparation of the apical third. Some authors say that it's better to enlarge it to a greater size in order to have better disinfection and a better reach of the irrigants. But some say that it is better to keep it as small as possible. So, but what I earlier also mentioned is, since apical third is a critical zone and the dentine thickness tapers down, it's lesser in the apical third as compared to the coronal and middle thirds. So we have to enlarge our preparations to an extent which gives us an acceptable debridement and at the same time doesn't weaken the tooth structurally. So the preparation sizes which were smaller didn't get good results. That is what we have concluded in the study. Further studies are needed in this direction. There must be different studies in different parts of the world evaluating different preparation sizes for the treatment outcome, and only then we can come up with a proper guideline that in case of these teeth, these type of teeth, we can have this much as a standard size. In case of these, until then, all we can have is that the initial apical width can act as a guide to enlargement to at least to an acceptable size, which gives us proper debridement and doesn't weaken the tooth at the same time.
Okay, QMARS, please.
I hope I answered your question.
Yes. Yep, good. QMARS.
And thank you very much. I have another questions. During root canal preparation with high flex, something unexpected may be occurred, such as debris accumulation at the apical third. And we need apical file such as 10 in order to extend it beyond the apical preparation for maintaining apical patency. But we didn't see in this setting of the methods materials, I think using 6 serial of the files cause debris accumulation at the apical third, and we must use hand file in order to patency. How do you manage this problem?
Or let's call it recapitulation. Do you use file for
Of course, we use recapitulation, and we use the patency file we use already in each and every case before going from one file to another file. The patency file is used first. That's not mentioned in the article. Everything is not mentioned in that.
Yes,
actually,
you didn't mention
in the article. Yeah.
You didn't, excuse me, you didn't mention it in the methods and materials. We only see the apical coronal enlargement fit 25.08, and then using the sectional file in order to reach the apical. You should, I think it's better to mention it in the methods materials. It's very important because the when you want to analyze the pain after endodontic, it's very important to remove the remnants and bacteria at the apical third. Thank you very much.
Thank you. You know, Professor Abu Tahun, we have a lot of very, very sensitive participants. They read the articles very, very carefully, and the questions show that even they don't miss a word in the article. And it is amazing. It is amazing. We need to be very careful when we write something, because we have a lot of eyes looking at that. Amazing. Thank you very much. And say hello to Professor, our legend, Professor Al-Nahlawi. Talal, ahlan wa sahlan. Thank you very much for joining us. So we are carrying on speaking about the article published by Shazra Fatima and Mukhtar and Rabi and their colleagues. And congratulations to them, because it is a very difficult job to do, a clinical trial, and they published that in a very prestigious journal. And thank you for the acceptance to join us, and we put them in a very hot chair. Okay, Massa, carry on.
Yes. A statistical analysis. For statistical analysis, the Shapiro-Wilk test used for assessment the normality of the data, Cruz-Carvallis test used for assessment of the outcome of the treatment and post-operative pain, Mann-Whitney test used for assessment of the outcome of the treatment and post-operative pain, and Friedman test used for assessment intra-group comparison at different follow-up intervals. Experiment correlation test used for assessment correlation between age, sex, preoperative lesion size, and post-operative pain and outcome. And the multinomial logistic regression show association between different independent variables and the outcome of the treatment. Uh, 120% were enrolled in the study, and 5 patients lost to follow-up and drop out, and so 115% or patients were evaluated for the assessment of post-operative pain and the outcome of the treatment. As you see in the flow chart, 120% patients enrolled to the study, and no one excluded. And according to randomization allocation, there was 2 groups and 2 subgroups. And in group 1, the apical preparation size was 2 sizes larger than initial apical bonding point, and in group 2, apical preparation size was 3 sizes larger than initial apical bonding point. And each group have a subgroup, and subgroup A had 4% taper, and subgroup B had 6% taper. And in group 2 also had 2 subgroup A and B according to taper. About post-operative, excuse me.
Yeah, carry on, we can hear you.
My slides have some problems.
No, we can see your slides, don't worry. Post-operative pain, we can see that. Okay, why?
Yes, post-operative.
Please, go ahead.
Post-operative pain, the intergroup comparison revealed no significant difference in post-operative pain between both groups at the interval of 6, 12, 24, 48, and 72 hours, as you see in table 2. And the intragroup comparison revealed a significant difference in post-operative pain between 6 and 48 hours and between 6 and 72 hours in two sizes larger than the initial apical binding file with the 4% taper group. APEC, age and sex and preoperative lesion size didn't reveal any significant correlation with post-operative pain. The cases with a periapical index score 2 or less and with the absence of clinical signs and symptoms at the 12-month follow-up were considered as success. So the success rate in group 1 subgroup A was about 57%, and in group 1 subgroup B was 92%, and in group 2 subgroup A was 93%, and in group 2 subgroup B was 96%. 3 cases from group 1 subgroup A and 2 cases from group 1 subgroup B didn't show a change in the periapical index score from baseline to the 12-month follow-up. A significant difference in the change in the periapical index score was revealed between group 1 subgroup A, means 2 sizes larger than initial apical bonding file with a 4% taper, and the rest of the groups at the 6 and 12-month follow-up, as you see in table 3. Multinomial logistic regression analysis revealed a significant association between the master apical file size and the preparation taper and the outcome of the treatment, as you see in table 4. And the intra-group comparison revealed a significant difference in the change in the periapical index score from baseline to the 12-month follow-up in all of the groups. And no association was revealed between other independent variables like age and sex and the outcome of the treatment.
Okay, please stop, Masa.
Yes.
Okay, thank you very much. There is actually a very important question by Professor Nair. Professor Nair, can you turn on your microphone, please? Professor Nair Abdussalam, Hello? That was about the quality and actually about the standardization of taking radiographs. Professor Nair, if you are in, please turn on your microphone. I ask you to unmute and also turn on your camera and speak, please. Yes, I think you are in. Hello, Nair. Nice to see you. Nair from Beirut. Okay, turn on your, please unmute your microphone. Nair, we cannot hear you. Please introduce, yes, now we can hear you. Please introduce yourself and ask your question.
Sorry about I am out of electricity, so I'm using hotspot, you know, the situation in Lebanon. I'm professor of periodontology and oral diagnosis. Thank you for allowing me to join this endodontic meeting. I'm really pleased to join you. I have just quick questions. When I read your interesting clinical trials, I'm used to use the VAS score and the X-ray as well in my research. The first question is, say it is a silly question or simple questions. The all 115 patients, did you manage to treat them all in the morning or in the afternoon? Or because my second question is, what about after 12 hours? So if you treat them at 3 or 5 o'clock p.m., will you follow up them at 4 a.m. or what exactly you did? The second one is when he is in pain.
Nair, please stop and let them answer the first question, and then we ask you for the second. Okay, Mukhtar, please. Or Shazwan.
I'm sorry, I couldn't understand the question fully.
I think the question is about the time of the treatment, because we know that if we do the treatment in the morning sessions, when we are ready for a good treatment, or in the afternoon sessions, it may have also some effect on the patients, because in the morning, if they are ready or not, it has some effect as well. And also, if we see the first patient, and then after that, the second and the third and the fourth, we may be tired also for them. So maybe there is a difference between the first and the last patient. The question is, are you standardized this variable or not? Am I right, Nair?
Yes, but the 12-hour assessment, after 12 hours, the pain assessment. So how they
understand. So the question is, if you did your treatment, for example, 6 p.m., how do you manage to measure the pain after 12 hours in 6 a.m. after that?
No. You see, we have mentioned it in our articles that the patients were trained regarding the use of VAS. We gave them a sheet of having a full diagram of VAS and asked them to place a line of the actual level of pain, what they think at particular time intervals, like after 6 hours, after 12 hours, and then at the next appointment, the patient, and that was telephonically confirmed by another operator of our clinic. There was one operator who trained patients regarding the use of VAS, visual analog scale, and he communicated with them telephonically. And the patients were themselves asked to place marks at particular time intervals when it was. And then after that, the next time when the patient came with the sheet marked, and those sheets were evaluated later on.
And if he is in pain, what medication he has taken?
Then yes, they were prescribed medication, analgesics, and actually that is, we have another part of the study, that is we have that data with us regarding the use of analgesics, how much analgesics were needed by a particular
but patient. You didn't mention this in this study, right?
Yes, that was the question as well. So if the patient used the painkiller, you should mention that in the study, how many of them did use the painkiller. And it has some effect also on the outcome measurement and post-operative pain measurement.
If certain patients had pain, they were prescribed a combination of ibuprofen and paracetamol in order to take. It's only if the pain was unbearable.
I assume definitely among the 115, some of them had to take some medication. It goes without saying that it happened, but you should mention it. How many patients did take?
Of course, that's a limitation that needs to be mentioned.
The last question regarding the X-ray. You mentioned the paralleling technique. You use the paralleling technique, but when you see the X-rays in the paper, they are in different angles, at baseline and post-operative. It should be more with pipe lock, additional silicone material to standardize the right positioning of the using the ring of the paralleling technique for better positioning, because there will be a variation in the. This is another point.
That is a limitation of working in a government hospital, wherein we have a radiology unit and the people are there who take the radiographs. So we try to standardize, we try to keep it as close as possible, but there will be some.
But you do a great job, and thank you again. Thank you.
Thank you very much.
Thank you very much for joining us. I know Nair, he's expert in oral medicine and periodontology, and his presence is very, very important for us. Thank you very much for joining us. And we will join to your periodontology online journal club to somehow compensate your questions as well. Just joking, just joking. Thank you very much. I know that Mukhtar did a great job and it was a very difficult study. However, there are a lot of limitations, and the goal of this session is to straightforward ask them the questions, and it is good for the future study. This is for the sake of the future study. Okay, Professor Shahsia, Professor Samira Shahsia, please you turn on your, unmute yourself and speak.
Hello, everyone, and thank you for your good literature. I just wanted to say that according to previous, lots of previous reliable articles, there is a straight relationship between preoperative apical lesion and post-operative pain. How can it be not related? You said that there is no significant relationship between these in your article. I just wanted to highlight this part of your literature, please.
Okay, Shazra, are you going to answer that, or Professor Andrabi, any of you? So the question is about the size of the preapical lesion and post-operative pain. Am I right, Samira?
Yes, you're right.
Okay.
Sir, as far as I saw the literature, I couldn't find much clinical trials that will assess the post-operative pain and the lesion size. Most of the articles were, the trials that I found was, they were assessing the effect of foraminal enlargement on the post-operative pain. And there was no mention of the lesion size, the articles that I could find. I would like to know from Dr. Samira, what specific articles is she talking about? Because as far as I know, there were 2 or 3 trials that assess the post-operative pain after foraminal enlargement. And foraminal enlargement will, logically, it would cause the post-operative pain because it results in extrusion of debris and irrigants and all in the periapical region. But to the best of my knowledge, I couldn't find any article that would relate the post-operative pain and the size of the lesion.
I think Professor Nazari Moghadam wrote something about this comment. Kumars, do you want to tell it to us yourself? And also Professor Talal is back and he has got another question. So QMAS, please let me read that. The most dominant factor influencing the success of root canal treatment negatively is the presence and the size of the preapical lesion, comparing preoperative large less than 5 millimeter versus a smaller more than 5 millimeter or less than 5 millimeter preapical radiolucencies. So this is based on the previous literature as well. QMAR's address to that. So the question is, if you have a very large preapical disease, we may have pain. So if you have pain, you show that there is no correlation between them. But I can help you for that by saying that they just select the small size lesion. They mentioned that in the inclusion criteria about the PAI score that for the inclusion criteria. That is very important. They didn't put all together and then compare that. So it was just about the small size of the preapical lesion, which is less than 5 millimeter or even less than 2 millimeter, I believe. Am I right, Shazda? Was it less than 2 millimeter? What?
It was between 2 millimeters to 5 millimeters.
2 to 5. So it is less than 5. Yeah. That means we don't have any effect according to the previous studies. In this study, it is also confirmed. So that is important. So thank you. I think, Samira, are you convinced? Good, good. That's good. So I'm going to ask Professor Talal Al-Nahlawi from Syria to unmute and also turn on their video and ask his question. There are some more questions. I go after that. Talal, please. Please unmute yourself. Yes.
Thank you, my friend. Thank you very much. I hope that you can hear me.
Yes, very
nice to see you again.
Thank you very much, Talal. I had a very good time in Syria. Thank you.
Yes, it was very, very nice. I don't know. I had some interruptions, so I don't know if the question was asked or not.
No. It is not. It is not answered and it is not asked. So I leave it to you. Go ahead.
Okay. I don't know if there will be an influence about the standardization in the average length. So for me, I think if we include it in the inclusion criteria, that we may select the teeth that they are almost with a range that almost maybe 20, 25, 20, 23 millimeters, they are almost the same or near to each other, because I think longer canals will continue more bacteria, the debridement will be more difficult comparing with shorter canal. On the other hand, shorter canal, the overall taper, if you make a sum or average of the taper between the coronal middle and the apical part, which will be the space inside the root canal, will be more larger comparing with longer canals. So would it be, or would it, do you think, influence the ability of debridement of the canal, so it will influence the results or not?
Okay, Mukhtar or Shazra, any of you?
Yes, what I could understand is that he's asking about that.
Mukhtar, please bring the microphone close again.
I will have to hold it in my hand. I think he's asking about the length of the canals, the length of the teeth. That whether the length was, whether there were certain teeth which were shorter and certain teeth which were longer, and yes. You see, the patients which we get in this part, we live in North India, and you see the length of the teeth usually varies ethnically, racially. So usually we get we don't get much difference in the length of the teeth which we get. It's just in a few millimeters, you say. So and your question is good, that in case of longer canals, it will be difficult to debride the entire, and that will of course, but in those cases we will have to strategize, and maybe in future any study we may design, or any other of our colleagues may design, where they may compare that canals which have or the teeth which have longer roots compared with teeth which have shorter roots, and then preparation sizes and outcomes in those teeth.
Talal, I think if we want actually somehow to put all of these variables in one study, it is almost impossible. It is almost impossible. clinical
Totally
studies,
understand
they
this.
have their own limitations in terms of the
Yes.
length, in terms of the width, as Mukhtar
Yes.
mentioned that as well. So, however, I'm in charge actually to ask all the questions from Mukhtar, but I want to help them for that because I did a lot of clinical studies. Limitations are huge.
Yes.
Limitations are huge.
My friend, I totally
Limitations.
understand because yes, doing a clinical study really is a very, very challenging topic, and we totally understand. But at the end of the day, going for in vitro studies, we have so many limitations, and also in the clinical. But I do believe clinical could be the impacted more important comparing with the in vitro. I totally adore everything, but just I want to highlight this issue because we can see a lot of cases that are long canals, and at the end they fail more. But the participant will not understand that the volume of the space, which will be in shorter canal, will be more comparing with the volume prepared in the longer canal in terms of ability of debridement, the ability for debris to go out. You understand me? So they will have wider spaces to go out. So it will be. So I just wanted to highlight, but on the really, I adore your work, and I enjoyed reading your article.
That's a very good point and a future research question, I think.
Very
Yes,
nice. Yeah.
of course. And that can be a topic of collaboration between different centers. Preparing a multi-central study, maybe Mukhtar can lead that as well. You in Syria, we in Iran, there in India, Professor Ibrahim in Jordan, and others. We can join together and prepare such things to look at different variables. Obviously, it comes to another question that we have received from Professor Zargar about the effect of the variables that you couldn't find any difference. When you couldn't find any difference in terms of regression, can we rely on that when you say there is no correlation? Do you think your sample size is enough for this result, or do we need more sample for that purpose? Obviously, when there is a difference and you show that there is a difference, your sample size and your statistical analysis is sufficient enough to prove that. But when there is no correlation, it is very difficult to prove that. That is the question. Please go ahead and answer that as well.
What we have said is in the negative correlation that in regression the effect was not of age, sex, and gender like this, not of size and taper. In terms of size and taper, they were significant. Okay, the effect was significant. And in terms of you see, every study, you can't say that now the sample size is adequate and we can extrapolate it to the population. No, I will say our sample size was just sufficient, but it was not enough for a complete generalization of all the conclusions and all the results of the study. In order for a complete generalization and a general guideline, we will definitely need either more studies or studies with much larger sample sizes in order to eliminate, or in order to actually establish what are the factors which actually have an effect and what are the factors which actually don't have an effect.
Okay, thank you very much. And there is a question from Khairuddin. I asked him to speak himself, but he said that his microphone has got some problem. So I'm going to read that question from you. He said that if you're talking about post-operative pain, did you use the same protocol of irrigation for all of the patients? Because one of them could be the result of passing through the APECs. The recapitulation with number 10 file is also important to eliminate the debris. I think we already covered some part of that, but because it is a question that we are receiving a lot, maybe you can emphasize again and quickly summarize the answer, please. Mukhtar or Shazur? Yes. Please answer the question. The question is about
irrigation, about the irrigation.
Irrigation, the effect of irrigation on post-operative pain, and the effect of packing debris at the apical sites, at the apical part.
The irrigation regimen, in all the groups was same. the irrigants used were all the same. They were from the same brand. The same brand needles were used, and the same amount, same procedure of activation, that's manual activation, was used in all the groups.
Okay. And another question, if we can adjust the variables between groups and mention them in demographic or initial table and find no statistical difference between group, it means that they can control the effect in. But they didn't mention that. You didn't mention that in the initial part. You did regression at the end. What was the reason of that? The question is, when you start, you may put all the variables in the inclusion criteria rather than just do the regression at the end of the study, or put all the data and try to stratify. I think you already answered this question as well about the randomization and the block randomization comparing to a stratified one, but it's good to repeat it again, please, because this is the question that we have received a lot.
Of course, we could have done that earlier as well, but that was maybe because the person.
Mukhtar, please bring the microphone close to your mouth. Okay.
That was that is how our statistician made us to do. Basically, the main point is that, and in future we will keep it in mind that we will first include it in inclusion criteria and try to. And regarding the stratified randomization, that was not possible for us because of the time span. That would have increased the time span of the study, and that would have gone beyond the course duration of Shazra Fatima, who's who had this as her dissertation in the masters. And also we are a government hospital. We receive a big pool of patients, and so it's easier for us to do block randomization as we receive a good pool of patients, rather than to have a large pool of patients, then stratify them. That will increase the waiting period for the treatment as well.
Yeah, I think that is a very good point, because in each of our school, we have received a lot of patients, and you did a very good effort to put them together and prepare a study. We all have this material, but you have this possibility to do that. You put all the efforts, and thank you very much for that, for the publication, because in endodontics, we don't have enough evidence, and you created a lovely evidence. Thank you very much. However, we know the limitation, and we know that you couldn't actually cover everything, obviously. So if you want to cover everything, you need a very huge funding, a very huge money and a budget for that. I know that. Okay, let's go back. Mrs. Sadeghi, let's go back. We are going for the discussion, okay? Mahsa, please share yours. Now we start the discussion part. However, we already discussed a lot, but Mahsa is going to present the discussion part. Shazra and Mukhtar, thank you very much. You tolerate our very harsh questions, and I hope this helps all of us for designing a better study in the future, although we admire your amazing job. Okay, discussion. Masa.
The primary outcome measurement was analyzed in two phases. First phase was post-operative pain after biomechanical preparation. A statistically non-significant difference in post-operative pain was observed at time intervals of 6, 12, 24, and 48 and 72 hours among various groups. Reasons for the non-significant difference in the incidence of post-operative pain among various groups was preparation 0.521 millimeters short of the radiographic apex while maintaining canal patency with number 10K stainless steel file, full limitation canal extrusion, absence of preoperative pain, and the placement of calcium hydroxide, and the use of rotary instrument. The patients can report a mild degree of pain for reasons other than the endodontic treatment, such as sensitivity due to clamp placement, sustained mouth opening, or local anesthesia injection. By the end of 48 hours, pain reduced substantially in all the groups. About 74% of patients had no pain, and 7.5% of patients had only mild pain. Therefore, a mild degree of pain is an expected outcome after endodontic intervention, and the intensity of pain reduces within the first 2 days. At 72 hours, only one patient complained of severe pain in group 1, subgroup A, and emergency intervention was scheduled. Second phase, about periapical healing after endodontic treatment and follow-up intervals of 3, 6, and 12 months. A significantly high success rate was observed with apical preparation 2 sizes larger than the initial apical bonding file, and a 6% taper compared with the same preparation size with a 4% taper. However, the success rate was almost the same when the preparation size was increased to 3 sizes larger than the initial apical bonding file with the 4% taper. In the majority of the cases, about 68%, the initial apical bonding file determined after corner pre-fillering was a number 15K file. As you see in the picture, 12-month follow-up radiograph shows healing in the periapical lesion in all the groups. About importance of the penetration, in an in vitro study comparing the effect of apical enlargement on the intracanal bacterial count, Calderon et al. Pointed out that removing the dentin in the apical third may not be necessary if an adequate taper is achieved that allows satisfactory irrigation of the canals. In contrast, many in vitro studies have reported a reduced intracanal bacterial count and endotoxin level with an increased apical preparation sizes. The significantly high success rate with minimal apical preparation and the increased taper attained in this study may be attributed to many reasons. First, penetration of the irrigation needle. Second, easy placement of intracanal medicament resulting in effective disinfection. And third, aids in the replenishment of irrigant. Butsuikis et al. Showed increased taper allows improved replacement of the irrigant and the distribution of shear stress of the wall apically to the needle tip, and so reduce the risk of extrusion. And mechanical agitation with gutta-percha cones that snugly fit at the apical foramen results in effective disruption of the vapor lock effect and providing a space for the irrigants to escape coronally. Size of the periapical lesion are known to affect the outcome of the root canal treatment. So only mandibular first molars with periapical pathology 2 millimeters or more and 5 millimeters or less were included in the study. And mandibular first molar were selected because it is most commonly involved teeth with pulpal and periapical disease, and the periradicular area of the mandibular first molars can be predictably and repeatedly radiographed by the paralleling technique, and it making Periapical Index scoring easier. About post-operative factors, extent and the quality of obturation. In this study, the obturation was terminated within 0.5 to 2 millimeters of the apex, and second is optimum coronal restoration after endodontic treatment. That in this study, quality of the coronal restoration was verified post-operatively and at every follow-up interval. Limitation of this study was the smaller sample size, shorter follow-up period, periapical radiographs for determining success, 3D imaging is better, and determination of apical enlargement size based on the initial apical binding file may be considered as the limitation of this study. The initial apical binding file may not represent the actual diameter of the apical region because of the high anatomic variability of the apical third of the root canal system. Coronal flaring, reducing file contact with the canal walls, providing straight line access and enhances the tactile sensation. And in conclusion,
okay, before the conclusion, please just let us go back to the authors because we're almost at the end of the sessions. First of all, thank you very much again from all of you for being with us so far. So let's have some of the questions. One of the questions, again, is back to the standardization of radiographs. So they look at the healing. When you're speaking about the healing as an outcome, the standardization of the radiograph is necessary. I think, Mukhtar, you already mentioned that as the limitation. Is there anything else that you want to add to this question, please?
No, I would like that in future, if somebody designs a study on the treatment outcome and uses three-dimensional radiography like CBCT or that, then that will be much more accurate and will be a much more concrete evidence. But in terms of radiography, this is all we can do.
Okay, and what about the obturation technique? Because you use same obturation technique for all of the cases. Obviously, you didn't evaluate the different sealers, different filling material, or for example, about the bioceramic sealers or anything like that. So can you tell us something about the obturation technique and potential effect of the obturation on post-operative pain and on long-term healing as well?
You see, as we were conducting a clinical study, we had to keep the obturation technique and the preparation technique same for all the cases.
Yes.
Otherwise, that would have, because if we use a different sealer, like a bioceramic sealer in some cases or something, that will have effect on the treatment outcome. So in order to keep that standardized, we use the same obturation technique in all the cases. We use the same sealer, and even the Gatta Pacha and sealer, they were of the same manufacturing company. So so that there is no effect of using different materials on that outcome. So
yes, but personally, that question is personally from you. So yes. What type of sealer do you use, or what type of sealer do you recommend? Do you recommend bioceramics? That is just a personal question rather than from your article.
Of course. Of course, bioceramic sealers are promising. They can give us predictable healing, especially because of their potential to increase biomineralization or promote biomineralization that will enhance the healing as well. But
that is another study. Obviously, your study, the goal and the aim of your study is different.
Different. Oh. And also in a government setup, in a government hospital where we are providing treatment to the bulk of the population, and majority of the population which is coming is poor, who cannot afford dental treatment outside. They come to the hospitals. So, and in hospitals, government hospitals have their own limitations. You can't get bioceramic sealers for if you are getting 100 patients for root canal treatment every day. So that's
good. That's good. I think this is also a very good symbol for all of us to run some studies like that, a good clinical studies that can be published in a very good journal, just using a very, very small resources in a governmental hospital like that. Congratulations to you, Mukhtar and Shazra and all of your team. But I know that Talal Al-Nahlawi, Professor Talal, if you please unmute yourself and give us some quick comment about the bioceramics, because that was a question that raised by one of our participants, one of the professors that she asked me that. Talal, if you can add something, because I know you did some studies about this bioceramics and the effect of them on healing. Can you turn on your microphone, please, Talal, and tell us something? While Talal is preparing himself, I may ask Zohre to send us some of those advertising videos from our sponsor. Talal, please be ready. Okay, Talal, thank you very much. Because I know you did some studies about bioceramics, please go ahead and give us that in 1 or 2 minutes, please.
Okay, sorry for I was out of coverage just for a while. Just to specify, I was not in the atmosphere of discussion. It was about what aspect?
Yeah, that was some extra question about the effect of obturation on post-operative healing, not just post-operative pain. And Professor Mukhtar and Rabi already mentioned that for the sake of the standardization of the group, he couldn't actually compare any obturation technique with others. That can be another study. Obviously, this study is just about the enlargement of the apical part. And obviously, for such a study like that, we need to keep the goal very small, not huge number of variables. I do agree with him. But the question is about the possibility of the effect of bioceramics on the healing. He already mentioned the potential of this bioceramic sealers. But because I know you did some studies about that, I asked you to add something to this, please. Talal? I think he is disconnected, I believe. Talal, can you hear us? Okay. It seems Talal is disconnected. Maybe he comes back. I think there are some quick studies as quick questions as well from Jassim Assad. I think no, Jassim just say thank you. There is another one about the eugenol-based root canal inhibits prostaglandin E2 production. Therefore, we have no pain.
Okay, very clear, my friend. Actually,
okay, Talal, please go ahead. I think the connection of Talal is not good, so he's coming back and going. All right, the question, Mokhtar, is about the use of eugenol-based root canal sealer, and because they inhibits prostaglandin E2 production, they may also help for that purpose. So I think these are just some comments, and we admire the comments that we have received. You want to add anything, Mokhtar?
No. Yes, of course. Whoever has said this is right. The eugenol we know is an obtundant. It has an obtundant action as well.
Mm-hmm.
But in case of sealers, I don't think whether it has been evaluated or ZOE based sealers have been evaluated for that aspect or not. I don't know about that, but that is definitely a valid point.
Okay, and also we have received actually some admiration about you and the whole program from our colleagues, Dr. Hofiani from Afghanistan. Thank you very much, Hofiani, for your nice words. Yeah, Mukhtar, please.
Yes, thank you very much, Dr. Kofiani.
Yes, Talal, please.
Sorry, back again to the subject of bioceramics. We know that one of the properties of the material that it's bioactive material. So, and we know on the other hand, actually, that it's been mentioned in so many studies that while we are doing obturation, the incidence of the material to go out of the apex is much more higher comparing with others. On the other hand, it was found in the studies and literature that this accident of extrusion of bioceramic sealer due to the increased flowability of the material, actually it didn't influence two things. It didn't influence healing, and on the other hand, it didn't influence post-operative pain. But actually till now, we don't know if the extrusion of the material will induce healing or not, as it is a calcium silicate material. I think it's very tough question. It's debatable. We need to know more about it. But still now, I do believe that the most important is the disinfection of the root canal. So till now, it's not obvious, actually.
Okay, that's what something that Mukhtar also confirmed. Thank you very much, both of you, and thank you everybody for joining us for this amazing discussion. I really enjoyed, I really learned from that. Thank you very much. So we're just going for conclusion, and then I'm going to ask all of you to turn on your microphone, and not now, just obviously, just turn on your videos first, because we are going to admire Shazra, Mukhtar, Masa, and everybody, and say thanks to them. So please turn on your video and be ready for the last part of the session. Masa, conclusion.
In conclusion, post-operative pain isn't influenced by the apical preparation size and taper of the instrument.
Good news. Guys, good news. Post-operative pain is not influenced by the apical preparation size and taper of the instrument. Okay. The second news.
Apical preparation two sizes larger than initial apical bonding file with a 4% preparation taper is insufficient and results in a lower success rate compared with preparations done with larger sizes and tapers.
So don't worry to enlarge the apical size a little more, and obviously, if possible, please enlarge the coronal part, because it gives you better access to the apical part to get rid of the bacteria. Third,
The minimum apical preparation size was number 25 with 6% taper, or 30 or number 30 with 4% taper in the majority of the cases.
Fantastic. That means we can respect the apical part. We are not going to explode the apical part by number 25 or 30, and tapering more give us this opportunity to keep it smaller, but tapering less, then we need to enlarge the apical part more. Fantastic. Thank you very much, Shazra and Mukhtar, for giving us this amazing information. And the last one?
And finally, further enlargement doesn't result in the further significant improvement in the success rate of the treatment.
Fantastic. Mahsa, first of all, thank you very much. I know you did a great job, so I leave Mukhtar to speak about your presentation and give a mark to you, because I know you are the second-year postgraduate student in Azad University. And Mukhtar, please. So can you please just turn off your share? Thank you very much for your presentation and your amazing job. Mukhtar, please.
Thank you very much, Masa. And you had done a very good presentation. You really studied the article thoroughly, and you got each and every section in your presentation highlighted in a proper way. And I wish you all the best for all your future endeavors. I hope that in future you become a very good endodontist and a good researcher and contribute to the field with more and more knowledge and expertise. And regarding the marks, I leave it up to Dr. Muhammad, and he is the most expert among all of us. So
okay, we put together our hands for Mahsa first. Mahsa, thank you very much indeed. Thank you very much. We are very proud of you and your school as well, and Professor Fazliab, if she's still with us. Thank you very much, Professor Fazliab as well. And I hope other schools from around the world, like the one that the Talal did previously with his postgraduate student, help us for our future work as well, because we are going to have Western zone time in 3 weeks, and after 3 weeks, Eastern zone as well. So sometimes on Saturdays and sometimes on Fridays, we are going to have our sessions. Mahsa, do you want to add something about your student, Mahsa? Please turn on your microphone. I hope you are not driving, because you are going to have some accident. Please park and speak.
The session took longer than I expected. I had to leave the house actually, but I didn't leave the meeting at all. And I need to thank you. Yes, I'm driving. I'm behind the wheel. Sorry, my eyes are on the road.
No, that's very active. That shows that this Zoom platform can help us to learn even during the driving. Be careful, be careful. Okay, Shazra, I want to... Okay, no worries. I will carry on, no worries. Shazra, I want to tell you something. You did a very difficult job, believe me. I'm in charge for teaching for around 30 years now. I'm not very old. I'm still very young, but I saw a lot of students. But believe me, doing a laboratory-based study is the easiest way that a postgraduate student can do. And you selected the most difficult possible study for a postgraduate student. And I'm sure without the leadership of this person that I love him a lot, Professor Mukhtar Andrabi, you couldn't do that. We put our hand together for Shazra Fatima for her very, very good job, and congratulate her for publication her article in Journal of Endodontics. Mukhtar, I don't want to thank you, because it is your job to teach your student. This is the Zakatul Ilm. You should actually transfer your knowledge to others. Okay, if you just let me to ask our hero, Professor Ibrahim Tahun, to end up the session, that would be my pleasure. Professor Ibrahim Abu Tahun, the stage is yours, and please end the session. Okay, unmute yourself, please.
Okay.
Yes,
Thank
we
you
can
very
hear
much.
you very well.
Yeah, I want first to congratulate you for this great session. One of the greatest sessions in our history, of course, with these webinars. Why? Because of the huge participation, which I can see here on the screen, and with more than 50 chats. And this happens for the first time. Well, this reflects the importance, the significance, and this great work of this topic. Actually, when we deal with very complex topic like anatomy and its complexity, and we all know that every tooth has its own tooth print. And this is why anatomy is a critical player and is a very limiting factor. We know that we don't have a problem with the irrigants. The problem is that with this complex anatomy that results in poorer in vivo performance of the sodium hypochlorite or any other irrigant. And this is a very important issue. And I want, before saying 2 words, to congratulate Dr. Mukhtar, Dr. Shazra for this great work. And I really felt sympathy with you when Dr. Mohammed was trying to squeeze you as if he is squeezing sealer in a lateral canal.
That's his job.
And now you did a great job. Thank you very much. And this question is very old. It has been raised by Dr. Mashtu. If bigger is better, years ago. And unfortunately, till now, we still don't have answer to this. But I think the most important is that we need our irrigant, our antibacterial agents to reach this complex anatomy at the critical zone of the tooth, because the load of bacteria is actually exists in this area, this critical area. And thank you very much for this great discussion, although it added more questions than answering questions. And we hope in next webinars, we can have much more, to reveal much more answers to this complex topic. Thank you all very much. Thank you, Dr. Mohammed. Thank you for the authors. Thank you for the participant. It was really great meeting you and looking forward for our next webinar.
Inshallah, thank you very much. And Professor Sanjay Miglani, unfortunately, because his mother has got some medical problem and he was in hospital, send his greeting to all of us. And we pray for the health of her mother. And also the father of Professor Hakkı Sunay in Turkey also had got some heart problem and he has got open heart surgery today. So we pray for all patients or COVID-19 patient, and hopefully they get well soon, very quickly, and be back together, inshallah, very soon for that purpose.
Thank you.
Okay, yes, yes, Shazra, please go ahead.
Sir, actually, our Professor R.K. Tiwari, sir, has joined and he wants to say a few words.
Our principal, the principal of our college, Professor R.K. Tiwari.
Please, thank you very much. Please, that's great pleasure. Hello, Professor Kumar. Thank you very much. Please.
Hello.
Congratulations to you by having this amazing staff and professors and students. Thank you very much. Please go ahead.
I joined first time and enjoyed a lot. There was a lot of questions which were in my mind and it was elaborated. I congratulate Professor Mukhtar, who is my colleague, that he answered all the questions up to satisfaction.
I'm his student as well.
Harsh question and everything. So I really enjoyed the thing, and I hope that I will continue in next meeting also. Thank you very much.
Inshallah, Professor Kumar. You know that in the initiation of the session, I mentioned that the newly indexed system for the academic evaluation in the world, which is not anymore about just citation to an article, but just speaking about the open science. Open science is a new index in terms of ranking of the professors and academics and universities around the world. So if a university is very open in terms of giving all the information to everybody and giving the courses freely to everybody, they get better mark and better index because they offer the science freely and openly to all the world. And the goal of these sessions is this online journal club and this discussion that is sponsored by Tehran University of Medical Sciences and run by the Educational Committee of APEC is that. And we are congratulate your university for that purpose as well. Thank you very much.
Thank you once again. Thank you very much.
Thank you very much.
Hope to see you again and all of you again. And thanks to our sponsor as well. And so we are going to say goodbye and good evening to everybody and see you in 3 months when we are going to discuss about the use of antiviral agents for evaluating the effect of antiviral agent on post-operative pain or post-abscess pain as well, published by Professor Sabati in USA. So I will send you all the information very soon and see you in 3 weeks in Saturday. Thank you very much and goodbye, everybody.
Thank you so much.
Thank you. Thank you.